57.
Who thinks B? Who thinks C? Nobody? Who thinks D? Okay. So it could be that he would die 20 years from now, and that's probably not because of his main disease.
Looks so nice.
Sorry?
His foot won't look so nice.
Yes, it doesn't look like a 70-year-old. Yeah, you're right. And do you know what's the main pathology in B? It's a neuropathic joint. We see the distraction and the dislocation and disorganization of the joint of the neuropathic foot. And what's the main pathology on the third one?
Psoriatic.
We see erosion on the distal phalanx, on the interphalangeal joint of the first toe. And it could be, of course, psoriatic. I think you're right. I think it's mostly psoriatic arthritis, but the sign that it is psoriatic is here. You see the telescoping of the metatarsus, and that's probably psoriatic arthritis. And here we see the classic erosion of gout with tophus around it, with overhanging edges. And tophaceous gout, usually the erosions are eccentric. We see that they are well defined, punched out. We see the overhanging edges. They're usually round or oval, and we like to say, although it's not always right, that they go along the long axis of the bone.
You have a backup.
Okay. Okay. What structures are calcified in this image? Easy for radiologists, should be. It is the Achilles tendon and plantar fascia, Achilles tendon and spring ligament, deltoid, ACL. Is that right?
No.
Okay. Now, which of the following images probably belongs to the same patient? Is it A, with those calcifications surrounding the joints of the hand? Is it B, with calcification within the shoulder joint, within the supraspinatus? Is it C, with those erosions surrounding the joint? Or is it D, with those big erosions and loss of joint space?
A and D.
Sorry?
A and D.
A and
D.
D. Okay, those belong to the same patient as the first one. Okay. Where is it? Previous one. Those belong to the same patient? A and D? Okay. We are not sure about it, because I thought it's B.
The patient has leprosy.
And what is the best diagnosis so far? Of this one at least? A, sarcoidosis, B, gout, spondyloarthropathy, or AGDD, which stands for hydroxyapatite deposition disease.
D.
Okay, right. So hydroxyapatite deposition disease is usually monoarticular, most common in the shoulder, but can occasionally occur in other places like the hip, elbow, wrist, and the knee. Can be asymptomatic. One of the physician sitting in front of me had very symptomatic one many years ago, used the x-ray of this doctor in my thoughts for some time. More in males than in females, and usually age 40 to 70. Now, chondrocalcinosis, we are talking about more generally, can be deposits of calcium pyrophosphate, calcium apatite, hydroxyapatite, the calcium phosphate, and calcium oxalate could be deposits within the cartilage. And we should remember that chondrocalcinosis per se is not arthropathy, is not necessarily symptomatic as arthritic pain, etc., etc. So this patient had hydroxyapatite disease, which also had deposits, as we saw, in the Achilles tendon and the plantar fascia.
Okay, so that's an easy one. What is the most formal diagnosis for this patient? Is it ankylosing spondylitis, psoriatic arthritis, rheumatoid arthritis, or DISH? What do you think? We see, of course, we see the syndesmophytes, and we see the syndesmophytes also on the AP, and we view that they are a little bit more horizontal. What do you think? Ankylosing spondylitis? Psoriatic arthritis? Rheumatoid? DISH? So we actually that both ankylosing spondylitis and psoriatic arthritis could apply. First of all, you know that psoriatic arthritis and ankylosing spondylitis both belong to the same family of the spondyloarthropathies that have the same end stage of bambooing the spine, though of course ankylosing spondylitis is the hallmark of this disease. And what's more sort of mnemonic, let's say, for psoriatic arthritis is the more horizontal, let's say, osteophytes seen on the AP view, though you can see that they have syndesmophytes just like that. So it could be both. Why isn't it rheumatoid arthritis? Because they just don't do that. And why isn't it DISH? Because in DISH, usually the syndesmophytes they are not even called syndesmophytes, these are osteophytes, are more bulky, or more thick, and they are more horizontal in nature, also on the lateral bone.
So, look at this spine. Iris talked about how osteophytes or syndesmophytes can look. Which sacroiliac joints belong to the same patient? So, look at this. Think what your diagnosis is, and look at this, and say which is probably the most reasonable diagnosis for, okay. What do you see in A? In A you can see erosions in this side and irregularity in some almost ankylosing here in the anterior part of the right side. In B you see a lot of erosions, but also a lot of sclerosis surrounding the joint. In C you can see air or gas within the joint, which in most cases will say this is not arthritis, right? This is not inflammatory. There is a lot of sclerosis on the iliac side of the joint. And here what you can see is the joint is pretty well spared for an elderly patient, but you can see this osteophyte that is here and also a small one here. So the diagnosis for those A and B will probably be ankylosing spondylitis or one of the family of spondyloarthropathies. Here, what will be the probable diagnosis in a woman, let's say? Osteoitis condensans iliae, of course, because there is no arthritis really, no erosions, but mostly sclerosis in both sides. And here, what will be most probable? DISH, right. So here you can see this osteophyte, which is very similar to the one that we've seen before here in those osteophytes, flowing osteophytes over quite a lot of joint spaces. Okay, so probably it will be D. Okay. So what will be the most probable diagnosis, as we said? DISH, right. Okay, DISH is a disease, not a disease. In many cases, the patients are quite asymptomatic, and you can see that the disc spaces are well kept, and you can see those flowing thick osteophytes anteriorly. In many cases, the disease will start in the lower thoracic spine and go down and up from there. This Iris has added a very, very nice case of DISH in MRI. You can see nicely the osteophyte here with very, very well preserved SI joints.
If a person has DISH, does it mean that he doesn't have ankylosing spondylitis?
If a person has lice, does that mean he doesn't have fleas?
That's completely true, because there have, first of all, there have been cases, and you will see in your cases that you just really hard to decide whether it's DISH or ankylosing spondylitis. And there have been numerous reports about DISH and ankylosing spondylitis together. So that's a whole body MRI image. And which one of these, we have three different patients, 1, 2, and 3. Which one do you think most probably has spondyloarthritis? Let's see what we see here. I think the images really come here dark, so I hope you can see all the findings. What do we see here? We basically see a normal spine, but in the anterior part of the vertebrae, and here you can see this is all T1. So what do we see? What do we think? We see if it's high signal intensity, it's probably fat. So we see some fatty corners here, very minor ones here, but the rest of it, maybe one here. The rest of it is almost okay. What do we see here? We see normal spine, and not really anything else. And what do we see here? Do you see? There's a lot of fatty deposition around the corners in many vertebrae anteriorly and posteriorly. So which one of those, most probably, if you had to choose one, would have spondyloarthropathy? The first, the second, or the third? First? Anybody else? So no, it's the third one. Let's go on. What do you think what we see here means? What is it? What are these changes? Are they signs of acute inflammation? Are they signs of erosions? Are they just chronic fatty changes? Or are these metastases? So these are fatty changes, and that part of the process of going of the inflammatory process in the spine of patients with spondyloarthritis, they begin with inflammation, which will be seen on T2 weighted images as high signal in the corners. They are related to the enthesis, to the ligament here, and bone marrow edema is related to enthesitis in that area. And then after the acute phase resolves, there's fatty deposition. It's basically very much like modic changes you see in the degenerative spine. And after fat deposition occurred, in some cases it becomes sclerotic, and then they will be seen on X-rays as shiny corners, the shiny corners that we know of. And here, for example, this is also the same process but occurring around the disc, and these changes are called, on the X-rays, in the anterior part they would be called Romano lesions, and on the disc side they will be called Anderson lesions. So this patient has a lot of lesions, and it was actually mistaken to be by a neuroradiologist to think that he has metastasis. but he has,
It shouldn't touch spine.
The problem is that many of the spine cases are read by neuroradiologists who have less awareness, let's say, of spondyloarthropathies than radiologists. We have a 36-year-old female with ankle pain. What is the main pathology here? Is it synovitis? Is it tenosynovitis? Is it bone marrow edema, or are there erosions? What do we see here? This is coronal T2 fat suppression. This is, I think, after the T1 fat suppression. And what do we see here? We see here, let's look at the axia, around the medial side tendons. You see here edema and enhancement. Okay, you can see the same thing surrounding the ligaments here, and also the tendons here, and you can see it also as well here. So what do we have here? The joints themselves look quite fine.
No, not subtalar.
Sorry, subtalar joint here. This is more like
No, sinostars is a lot of synovial there.
Yes, but it is not
A
a
lot.
joint. Sinostars is not a
Usually
joint.
it's extension.
Has interosseous ligaments, but it's not a synovial joint.
But they usually put the extension of the subtalar.
You're right.
The
But
subtalar
you-
joint is here more likely. This is the
One of them.
sinostars which has
One of
edema in it as well. Okay, so what will be most probable? Most probably, yes, it's tenosynovitis, because the bones look quite fine, the joints that are demonstrated here, like this one, like the medial subtalar joint, look quite fine. There are no erosions, and this is mostly tenosynovitis of the joints surrounding them.
What was it? Tenosynovitis from what?
So if you see a patient who comes in and you know that sometimes they just come in and of course you get the report and what did they say? Pain. And you have no other, but you see that tenosynovitis, fluent tenosynovitis all over the joint. Most of the time you will see also synovitis, but it's not necessarily, you must think of a rheumatic origin. That,
Could be reactive arthritis, could be rheumatoid arthritis, but you have to go on.
okay. I have that. That's the hand of a 52-year-old female that guess what? She has pain. Do you see anything? Soft tissue edema? Soft tissue swelling? Erosion? Anything?
Yes, with the hand, with the
I don't see anything.
thumb.
Well, how would you go on? Will you do scintigraphy, ultrasound, CT, or MRI? I have to say that ultrasound is not a bad option. I think ultrasound for the hand is great in the right hand. CT,
Or the left hands too.
I wouldn't recommend the CT, and MRI is also of course good, but this person is MRI. And that's the MRI of this patient. So this is T2, this is T1. We see cortical discontinuity along the bone. You see these erosions all over. Here. We see a lot of synovitis. And we see bone marrow edema where the erosions are, and in some places where there aren't any erosions. Okay? And we also see, what's that? Tenosynovitis is extensor cardioradialis. They will know. So what do you think the most probable diagnosis is? Rheumatoid arthritis, erosive arthritis, psoriatic arthritis, or gout? RA, yeah. And why do we think that this is RA? We see all these inflammatory findings. We see them in the proximal part of the joint. We see them in the carpus, and we see them in the metacarpophalangeal joint. So this is a clue that it's rheumatoid arthritis, while erosive and psoriatic arthritis are usually in the distal part of the hand or the feet. And gout? Gout we usually see anywhere. So usually when you see something that doesn't make sense, when you see something that is in the distal part and also in the proximal part, and in the radial part and ulnar part, and you don't know how to make of it, think of gout, because usually it's more crazy. Okay.
We have a 28 years old male with pelvic pain. I have no idea, let's do an MRI. There is left side sclerosis, let's do an MRI. The right side sclerosis, let's do an MRI. The left side sclerosis, we know the diagnosis, so let's give him steroids, or the rheumatologist give him steroids. What do you think? A, B, C? A, B, B, and C I wrote, okay, that's fine, yeah. A, B, B, or C, yeah.
B and B.
Proofreading,
and B.
right. The first B, I think, will be right, okay? Okay. Here we have an MRI of the same patient a few months ago. What do we see here? We see here, there is in the T1, we can see here that there is irregularity, some sclerosis, and some erosions at the iliac side of the sacroiliac joint on the left. You see how quite nice the sacral side looks. But here we can see there is fluid within the joint. You can see here quite a lot of edema. Post-gadolinium. Who of you give gadolinium for sacroiliitis? Usually I do. Yeah. Okay.
But you should know that it's not recommended. We do too.
It's controversial. It's not controversial. Some do, some don't. Okay. We can see here enhancement within the joint, and we can see here edema surrounding the joint. So what we have here, we have most left side sacroiliitis. So what do we have here? Is it active sacroiliitis? Is it chronic erosive sacroiliitis? It is active and chronic, or is it the normal MRI? Sorry? A. Is it A, B, C, or D?
Only active?
Only active? No, I think C, because we have erosions here. Erosions are part of a more like chronic type, I mean advanced type. Okay? So we have here sacroiliitis with active and chronic together, and this coexist almost always. Okay? You can see the advanced things and the more active things. Okay. This is the same patient with the spine. This is T1, this is T1 fat suppression after gadolinium. There are chronic fatty changes, there are acute inflammatory changes, both are correct, or this is a normal spine. What I see here, and it's a little difficult to see, but we can see here some fatty changes in the anterior part, anterior corners of those spines which do not enhance. We can see them here, but almost no enhancement here. So this is quite subtle, but there is involvement in this patient in the spine as well. This is why, even if I'm requested to do, as a joint, I always tell my techs to do lower spine. I don't even call it lumbar spine. I call it lower spine, and as much as it takes, you know, in one field of view. And this is, in many cases, we can see those changes. So, what do we have here? Mostly chronic fatty changes in the spine.
Guido,
Yeah.
can you move it?
Again.
There is some enthesitis at the supraspinous ligament.
Okay.
You can see after gadolinium.
Yeah.
Free fall.
You can see it here.
Free fall.
Sorry?
Free fall.
You
Down.
can see here some.
No.
Free fall.
Supraspinous.
I thought?
Supraspinous
Posteriorly.
ligament.
Posteriorly.
That is in
Yeah,
the
right. Okay.
In a small
Right,
percentage.
right. You're right. So there's also active change.
But maybe we should point out that you know that when they're doing MRI of the spine, I don't know how you do it in France, but in Israel, mostly the question is disc, right? Usually, and what you do, you never get
Sagittals.
the parasagittal parts of the spine. You only get the central. You get everything.
We perform coronal slices all the time.
So they hardly do corona.
Like the
so
cells, you know?
exactly. So you miss the enthesis.
Yep.
You miss the facet
And
joint
sacroiliac, and we perform sacroiliac joints all together.
together.
Yes.
Okay.
For the same place.
So this is the same patient 6 months later after he got treatment. What do we see here? You can see here that there is much less edema, much less enhancement, still some erosions here, okay? The joint looks as if it is a little wider perhaps, but there is much less edema and enhancement after gadolinium. So here we can see what is the correct answer for this. The inflammation has improved, the sclerosis disappeared, there is now right-sided arthritis, the same findings as before. I think it's A, okay? As we said. So as you can see, those are the first findings 6 months later. What would be a good probable diagnosis for these patients? Ankylosing spondylitis, rheumatoid arthritis, septic arthritis, or reactive arthritis. There is no Reiter disease anymore. It's called reactive arthritis. Anybody does not know why there is no reactive arthritis and no Reiter disease anymore? Reiter was one of the worst war criminals in the Nazi regime. He was probably responsible for the death of 170,000 people by doing eugenetics, as it's called, I mean killing the poor and the weak and the poor by doing experiments on people in Buchenwald. He was one of the worst Nazi criminals, so today there is no Reiter syndrome anymore. Call it reactive arthritis, okay? So what will be a reasonable diagnosis here? A, B, C, or D?
D.
I would say also ankylosing could be, but also reactive arthritis, more probably reactive arthritis because of the unilateral of it. This patient has chlamydia infection and then he had this sacroiliac joint disease.
So, we see the hands and fingers of a 76-year-old woman. Look at the MCP joint.
Foreign body?
Look at the PIPs and the DIPs. There are several very typical findings. And if you didn't see that, that's large. Okay, think about the diagnosis. What do you think? You have it here, if you don't remember. What is the probable diagnosis? Is it erosive arthritis because of the central erosions? It could be erosive arthritis, but these are only seen in males, so it doesn't make sense. Is it psoriatic arthritis?
Why?
Look at the distal changes, so it must be psoriatic arthritis. Is it reactive arthritis? That is exactly the age to have it. She's 76. So what do you think? Is it A, B, C, or D? Anybody think anything else but A? Okay. So this is really erosive arthritis. Yeah. So we can see the erosions, the seagull type erosions in the distal part, and that's really typical for erosive arthritis. Of course, these are typical for women. You could see other joints as well, but this is more typical, and the central erosion. So that's typical erosive arthritis.
This is a 48-year-old woman. Which hip, she has hip pain, but which side is painful? Left, right, both, none. Okay, she has right hip pain. Anybody sees anything pathological here? Okay, let's do enlargement. Yes, we have here crescent sign. You see this lucent line that is parallel to the joint, to the cartilage line here, the cortical line. This is called crescent sign. It's very typical of. Now, this is an MRI of the same patient. Okay, what do we see here? See the well delineated line here, which is on regular T1, is quite darker. I mean, it has